The mechanical ventilator. It's a machine that we often associate with the most intense, critical moments in a hospital. But it doesn't have to be some kind of medical mystery. Really, it's just an incredibly sophisticated tool, one that's designed to be a bridge, helping a person get from critically ill back to health. Today, we're going to pull back the curtain and demystify it by following a patient's entire journey, from the second it's needed to the moment it's not.
So, let's just get right to it. What really happens when someone is on a ventilator? I mean, beyond all the beeps and tubes you see on TV. We're going to dig into the why, the how, and what comes next, looking at this whole process through the eyes of the medical team making the decisions.
Okay, so first things first, let's talk about the starting point. Why does a patient even end up needing a ventilator? This isn't a call that doctors make on a whim. It's a decision based on some very specific, very clear signs that the body's own breathing system is just overwhelmed.
And it really boils down to these four critical problems. First up, the most obvious one. The blood just isn't getting enough oxygen. That's hypoxemic failure. Second, the flip side. The body can't get rid of enough carbon dioxide. That's hypercapnic failure. Third, and this is a big one, a patient might be so out of it that they can't protect their own airway from, saliva and other secretions. And finally, if the body's pH balance gets way out of whack, a patient can start breathing so fast that their muscles just give out from exhaustion. Any one of these is a major red flag.
Now, here's a super important distinction that doctors are always thinking about. Hypoxemia just means your blood oxygen is low. You can actually be hypoxemic and be, kind of stable. Hypoxia, on the other hand, that's the real danger zone. That's when your body's tissues and organs aren't getting the oxygen they need to survive, and they start to get damaged. So really, the whole name of the game is to stop hypoxemia before it turns into hypoxia.
All right, so the decision's been made. A ventilator is needed. But how does this thing actually work? I promise it's not just a machine randomly pushing air. No, it's a very precise system with very specific jobs to do.
And this table breaks it down perfectly. You see, the vent really has two main jobs. Job number one is ventilation, which is all about getting carbon dioxide out. And you control that with two dials. How much air goes in with each breath, that's the tidal volume, and how many breaths per minute, that's the respiratory rate. Job number two is oxygenation, getting oxygen in. And that's controlled by the percentage of oxygen in the air, the FiO2, and this other fascinating setting called PEEP. Which of course brings us to the big question. What in the world is PEEP? Of all these settings, it's probably the most crucial and, honestly, the most misunderstood. The full name is positive end expiratory pressure, but what it does is actually pretty easy to picture. And here it is, the perfect analogy. Imagine you're blowing up a brand new balloon. That first puff, right? It's always the hardest. But once you get a little air in there, every puff after that is way easier. Well, PEEP does exactly that for the lungs. It keeps the tiny little air sacs, the alveoli, from completely collapsing flat after every single breath. It keeps them open for business, making the whole process of breathing so much more efficient. Now, you might think it's all about the machine, but that's just one piece of the puzzle. Being on a ventilator means being part of this whole ecosystem of care, this comprehensive, around-the-clock system that's designed to support the entire body, not just the lungs. And to make sure they don't miss a single thing, a lot of ICU teams use a mnemonic, a memory aid. This is a great one. FAST HUGS BID. I mean, how great is that? Each letter stands for something absolutely critical that has to be checked every single day. Things like nutrition, pain control, preventing blood clots, and even giving patients a daily sedation holiday, a little break from sedation to see how they're doing, which can actually help them get off the ventilator sooner. And all the while, the team is watching these pressure readings like a hawk. They're trying to avoid something called barotrauma, basically lung damage from too much pressure. It's really cool. They can tell what's wrong just by looking at the numbers. A high peak pressure is like trying to push air through a clogged pipe. It suggests there's resistance, like in an asthma attack. But a high plateau pressure, that suggests the lung itself has gotten stiff and doesn't want to expand, like in a condition called ARDS.
The way we manage ventilators today is light years ahead of where we were just a few decades ago. And that's all thanks to some really smart people and some game-changing clinical trials that have totally rewritten the rulebook, making ventilation so much safer.
And it all kind of started with this one, magic number, 6 cubic centimeters per kilogram of ideal body weight. This number came out of a massive, revolutionary study called the ARDS NET trial, and it proves something amazing. Using smaller breaths,
Less air than we thought was necessary actually saved lives. It prevented the lungs from being overstretched and damaged. This idea, low tidal volume ventilation, is now the absolute standard of care all over the world.
And that study taught us something that sounds kind of backward at first, this idea of permissive hypercapnia. Basically, to keep those breath sizes and pressures safely low, doctors will actually let a patient's CO2 level get a little bit higher than normal. It's a trade-off, right? You accept a slightly off blood test in exchange for protecting the lungs from physical damage. It's brilliant, and it saves lives.
And that was just the beginning. The learning didn't stop there. Another huge trial showed that for the sickest patients, simply flipping them over onto their stomachs, it's called proning, could dramatically improve their oxygen levels. Then another one showed that for the absolute most severe cases, temporarily paralyzing the patient could help by letting the ventilator do 100% of the work, giving the body a chance to rest and heal.
So, after all of this, all the settings, the checklists, the scientific breakthroughs, it's all pointing to one single goal: getting the patient strong enough to start breathing on their own again. This whole process is often called weaning, or even better, liberation. Okay, so check this out. Here's a little nugget of wisdom from the ICU that might totally surprise you. The philosophy is that you want to be pretty aggressive about taking the breathing tube out. The longer it's in, the higher the risk of other problems. So the thinking goes, if you never have a patient who fails and needs the tube put back in, you're probably being too cautious and leaving people on the ventilator longer than they need to be. It's a really delicate balance.
So right before they pull the tube, there's this one last super important safety check they do. It's called the cuff leak test. They deflate that little balloon that holds the tube snugly in the windpipe, and then they listen. And what they want to hear is the sound of air leaking around the tube. Hearing a leak is actually a great sign. It means there isn't a bunch of swelling in the airway that could close up once the tube is gone. If they don't hear a leak, it's a no-go.
And then there's often one last test score to calculate. Think of it like the final exam before graduation from the ventilator. It's called the RSBI, or Rapid Shallow Breathing Index. When a patient is doing a breathing trial on their own, the team measures how fast they're breathing and divides it by how much air they're moving. And if that number is less than 105, it's a fantastic sign that they have the strength to make it on their own.
So when you look at the whole journey, from needing total support to finally breathing free, the ventilator is exactly that, a bridge, a temporary life-saving bridge to get someone through a crisis and back to recovery. The whole process is this incredible dance between machine and biology, guided by decades of science and minute-to-minute care. And it really makes you wonder, right? What does this journey truly teach us about the incredible, almost unbelievable resilience of the human body? Thanks so much for joining us.